Hi, I'm Bill Santamore of Hospitals and Health Networks magazine. I'm here today with Dave Brooks, CEO of Providence Regional Medical Center, Everett, Washington. Dave is at the AHA Health Forum Leadership Summit to give a presentation with his CMO, Larry Schechter.
Right.
And the name of the presentation is Achieving High Quality, Low Cost Care, a Case Study. Thanks for coming.
Thank you for allowing me the chance.
Can you give us some context about your talk by briefly describing your organization and the community you serve?
Sure, be happy to. We are a ministry within the Providence Health and Services health system. We predominantly serve Snohomish County, which is the community just north of King County in Seattle, so we're in North Puget Sound. Snohomish County is made up of about 700,000 people, so it's a pretty large county in itself. The Providence Ministry in Snohomish County has about 3,500 staff members, medical staff of over 800 physicians, and about 900 volunteers. Okay. And we're organized around...
How many beds do you have?
Pardon me?
How many beds do you have?
We're about a 400-bed tertiary hospital.
Okay.
And that's Providence Regional Medical Center, Everett, the hospital campus itself. In addition, we have about 90-member medical group, Providence Physician Group, that we sponsor. And we have a full-service home care and hospice agency, Providence Hospice and Home Care of Snohomish County.
Okay. Now, the subtitle of your presentation is One Community's Journey to Value.
Yes.
How do you define value?
You know, the simple answer on that, as defined by organizations like Institute for Healthcare Improvement in Dartmouth and other academic and kind of leadership organizations, is value is really quality over cost. If you think about it, it's a pretty simple formula. Serve our communities, we really need to be focusing on how do we improve that value. How do we improve the quality of our care and the quality of our services, yet create more access for people, for everyone in the community to access our services. The cost piece probably impacts more that second component, the access component, right? If you think about it. But again, the simple answer is it's quality of service and care over the cost of that service or that care.
Okay. So when you started out on this journey, did you set specific goals?
Yeah, we had goals that were both organizational as well as programmatic. And I think that ended up helping make sure that the leaders of the organization were very connected with the caregivers, the clinicians. Our organizational goals were kind of set up as an entire health system around our quality strategic plan, which is basically built around the comprehensive balanced scorecard approach. And it's a pretty audacious set of goals, which is to be at the top 10% in the country around every dimension in that balanced scorecard: service, quality, financial performance, community benefit, and so on. At the same time, we had physician-led performance improvement teams that were setting goals in their particular areas of expertise, generally around evidence-based best practice standards, adherence to nationally endorsed guidelines and standards of care. And I think for us, kind of having that combination of kind of the macro system, best in the country, top 10% in each of those dimension goals, along then with team-based goals in their particular area, and that kind of that combination of that macro system and those micro systems really accelerated our development.
Okay. Well, what were some of the steps you took?
You know, there were a lot of steps, and I think we're still taking it, frankly. I don't know if it's over. I think it's going to be a long journey.
Right.
But some of the bigger pieces, I think, along the way, some of those bigger steps, the bigger activities, you know, we've defined accountability or within the organization around those various measures of success. You know, who's going to champion service excellence, and then how do we organize ourselves around it? Who's going to champion clinical performance improvement, and so on. So you've got to organize yourself around it, and that usually starts with defining what's the accountability structure is going to look like. We've really recreated the relationship between the medical staff structure and the medical staff and the hospital, and that's been an accelerator.
How did you do that?
We've reformed the medical staff. You know, it's a large hospital with a large medical staff and relatively traditional private medical staff in that it's diverse and it's made up of a number of different groupings of physicians, some employed, some private. And we've merged the models of the medical staff to be both the private elected medical staff leaders along with hospital-appointed leaders and created one medical staff. Most hospitals have a private structure of elected physician leaders on their medical staff who focus on quality. And then there's medical directors who focus on programmatic goals in an area, usually on some type of compensation methodology with the hospital. We've actually brought the two together. So there's a physician champion over a clinical area, and they're the champion of everything: quality, cost, growth targets, physician and staff satisfaction, etc. Really a unique structure for a private medical staff.
Were there other steps that you wanted to?
There were other steps. We've really focused on creating a very rigorous methodology and approach to the financial aspects of how we organize the organization to make sure that we stay extremely focused on resource use. Again, the denominator portion of that formula, the cost portion. We've promoted innovation in both structural as well as clinical project management within the organization, and we've really, I think, recognized the intensity and the acuity of what happens in a hospital by our hospitalist program. You know, like most hospitals, we have an internal medicine hospitalist program, but in addition, I think we're up to having 8 other specialties that have hospitalists within the organization, and we have a couple more under development right now. Wow. Again, changing the way kind of the physician aspect of care is delivered within the hospital.
Okay, can you talk about some success stories you had?
Yeah, and I think it's a series of stories. Again, I think we're on this long process,
right.
So it's hard to say organizationally we're at a success point, but we certainly have had programmatic success, and I think that's beneficial because it keeps momentum going, right, as you're able to demonstrate that internal. One of the more dramatic areas that I'd probably highlight is what's called our cardiac single stay unit, or CSSU. Traditional approach a hospital has to do open heart surgery is, you have the surgery happen in the operating room, of course. Patient is recovered, goes into a critical care unit or a cardiac care unit, spends a day or two there getting strong and stable, is transferred then sometimes to a step-down bed, sometimes to a cardiac bed. If they've gone to a step-down bed, then they're transferred after some other stability into a cardiac bed, and then gets hopefully discharged home, is kind of the traditional process. We, through a physician leader and a nurse leader who heard about a program, researched it, have had in place now for about 6 years a total redesign of that. We have a cardiac single stay unit, which is exactly that. A patient comes out of surgery and goes into that unit, and that's pretty much where they'll stay until they're discharged. So instead of moving the patient through the hospital, around the hospital, we move the hospital around the patient, if you think about it, right? So the room starts off very high tech when the patient is coming out of the operating room into that room. All the machinery, all the caregivers, all the various subspecialties needed. And as the patient progresses, a lot of that equipment and the types of caregivers start coming out of the care process until basically they're ready to be discharged. It's meant total redesign of our clinical and operational processes around the way the patient and the clinical service happens, not around how the provider wants services to happen, right? If you think about it. It's decreased numerous steps or clinical handoffs, which has created more efficient and maybe more importantly, safer care, right?
Right.
We've reduced length of stay by half a day. We were already one of the benchmarks prior to this program for length of stay for heart surgery patients. And with that, the waste in the system, we've knocked another half a day off of our length of stay. Meanwhile, our readmission rates, patients discharged after open heart surgery, our readmission rates have actually decreased, showing probably better care. Our infection and other complication rates have decreased since this unit opened. This unit has the highest level of patient and staff satisfaction in the various surveys that we do, almost always ranking in the 95th, 97th percentile in the country on those metrics or those measures. And if you think about it, we do about 500 open heart surgeries a year. Half a day or so off that length of stay has really created capacity for us to service 40 more open heart patients within the organization per year without having to add any more resources to do it, right? So overall, we've lowered the cost of those resources for the community.
You had mentioned CABG, blood utilization, as one of your success stories.
Right. Yeah.
Can you talk about that?
Sure. We found ourselves also in our heart surgery program based on the leadership, again, of a physician and a nurse leader, clinical leaders, driving this. We looked at open heart surgery and the use of blood products, transfusions, during it. And we were running about probably country's average at the time, and this was about 5 years ago as well, where we were running probably about 40 to 50% of the time during open heart surgery, some level of blood product was needed. And they just started to look at that and design ways to reduce the use of blood products, yet improve care, right? And over about a 4 to 5 year period, through a lot of innovation and leadership by them and others around them, we're now down to using blood products less than 10% of the time, right? So less than 1 out of 10 patients needing open heart surgery, right? The opening of the chest, need blood products as part of that. Better care, less resources. We estimate we've saved probably about $2.5 million in the actual cost of the blood product, which is a scarce resource in every community, right? And obviously an expensive one. And there's an estimate out there of about, for every dollar you spend on blood product, you probably spend about $5 in the processes to store it and handle it and so on. So that's probably upwards of about $10 million in savings in blood product usage and better care.
You say that achieving high-quality, low-cost care requires a, quote, relentless pursuit of excellence. What do you mean by that?
You know, we're never satisfied. That's a blessing and a curse, by the way, but we're never satisfied. No accomplishment is kind of considered is good enough. The better we end up doing at something, the more we end up wanting to achieve in it. And again, there's a double edge to that, and that you have to still keep the team motivated and passionate, but at the same time, I think we strive that. I think a lot of it comes from our mission and our core values as an organization, being a faith-based organization. And one of our core values is respect, right? And I think if you have a passion for respect of the patient and respect of the community, you almost always want to be the absolute best at what you're doing for them. I mean, when either myself or my family needs health care, that's what I expect from my clinical institution, the absolute best for them. Why would we not tolerate that, or why would we tolerate anything less than that for any of the patients that we're serving, right? I don't think that's what they expect, and if we truly respect them, we're going to do that. And I think that's the accountability we have to serve our communities.
Well, thank you for being here. Appreciate your talking to me.
Appreciate the chance. Thank you.